This is working.
No, this got it.
Yeah, we are going to be live streaming. It says it's setting up.
It says meeting is now streaming live.
We are now, I think we are doing it. It looks like it's up live to me. So it always takes us a moment. Thank you to the people who are waiting on us here. But it looks like we're live, and we got a special treat of bringing our dizziness expert, Jaimy, on board with us today to talk about those common questions that we get about dizziness. And in particular, we started with this idea, actually, this was your idea, Jaimy, of the dizziness mixtape. And then we got a lot of questions on type of activity and dosing of it, and how do we incorporate this whole sensory reweighting idea for treating dizziness in a different way, like beyond the VOR, right? So we get a lot of these questions. I personally have a lot of these questions, so I'm really excited for you to share with us. And maybe just to start with a little recap, because we chatted with your counterpart, Catherine, on Wednesday about this idea of a mixtape. And then, so if you could just kind of reintroduce us to that and then talk about how we bring this into exercise, like dosing and a home exercise program. So I'm going to have you take it away.
Okay. Thanks. Thanks, Julie. Thanks for having me. It's been really fun. The idea of the mixtape is that if you're a person of the 80s at all, you recall making yourself mixtapes, and they were really set up for whatever scenario, like breaking up or exercise playlist is what they would probably be the new term now. But the mixtape for PT and dizziness would be more aimed towards really personalizing a program for each person that comes in. And what Catherine and I have put together is really a nice way to do a sensory weighting analysis. And that's what we're kind of calling it. Let's analyze the impairments, but let's really look at what is happening in the sensory weighting component, or the connectivity that's going on in the brain. So is the person more heavily weighted in the somatosensory system, or typically the visual system, right? More people tend to dive into visual dominance and visual motion hypersensitivity. And so the idea was not only creating the tape for the patient, but also the PT, like, oh, let me pull out my mixtape for that visual motion hypersensitive person. Let me pull out my mixtape for visual dependency, and really trying to identify where does that person fall into sensory weighting, and then how do we really prescribe and dose and exercise for that patient. That might be the patient's mixtape. So then we look at visual dependency. Maybe we need to do more eyes closed activity for that person because we want to reduce the visual dependency, and maybe reweight the somatosensory system instead of the vestibular system, again, depending on the patient. We might have a patient who has visual motion hypersensitivity or even canal hypersensitivity that really has a low tolerance for activity. And so let's develop a very prescribed dosed program for that person, really based on a lot of the optimal theory principles. So let's give them autonomy and tell them, how much can you dose? Do you really have to do a minute of VOR, or can you just go beyond and get that air signal? And it's still effective so long as we get an air signal, and giving them the chance to push through, and really designing that program, again, based on hypersensitivities and dysfunction. The more Catherine and I discuss, like, the person who has dysfunction might not have quite as much sensitivity. They might not be quite as dizzy, and they can tolerate a really strong program. They kind of fall into that that typical program that we give them, turn your head, do VOR, stand on foam. But then there's that other group that definitely needs that mixtape for that hypersensitivity and really coming down and breaking down the autonomic nervous system and that response to their dizziness, the certainly the canal response, the otoliths response, the somatosensory response. Some people have somatosensory hypersensitivities as well. And so kind of going there. Any other points I'm missing, Julie, that
Yeah, I mean, I'm thinking, and I'm going to keep an eye on our comments too as people are watching live, because I'm wondering if other people may wonder, like, can you differentiate, maybe just briefly, because I know this is like the whole course, but
of course, but sure.
what is like dysfunction versus hypersensitivity? Like, how would you define that? Not only for the therapist, but often we'll have people with dizziness who watch these videos and they're like, what is she talking about? So, you know, I think for a lot of people, this is maybe kind of new.
Yeah.
I think in the healthcare world, in the medical world, we think primarily of like a pathology and dysfunction. Now, you know us, we often think of how sensitive these systems are, and we live in that world a lot, but not everybody does. So can you help just distinguish a dysfunction from a hypersensitivity?
Yeah, let's do an example. A good example would be like a true oculomotor dysfunction. So let's say that this person has trouble, has a convergence insufficiency. We'll call that's dysfunctional. But then you have, on the other flip side, you have the patient who has a very normal convergence, but they're hypersensitive to the motion. And it's not to say that the dysfunction can't lead to hypersensitivity, but there is a difference. And I think gets confusing because the patient's sensitive, they might even appear slow, or there's a little something there, but it's more that they back off. They can't look at, they can't look at when you're doing a convergence test. It's more like they're sensitive to it. And so we're going to treat convergence insufficiency very differently, and or refer out to neurooptometry depending on the severity and how it's impacting their life. Mm-hmm. Versus I just want to really reduce that maladaptation or that functional connectivity that's going on in that person with visual motion hypersensitivity. So then again, looking at the research saying, why is there so much going on functionally with the person with visual motion hypersensitivity? Just like all those beautiful slides you show about functional neurologic disorders, that occipital lobe it's just overfiring. And so how do we reweight the systems to reduce that overfiring of activity or that functional connectivity that's going on? So that's a nice, clean, distinguished, like we see a lot of convergence insufficiency, and they can do it all day long. It might strain, it might give them a headache because the motor recruitment is poor and there is a dysfunction there, but they don't necessarily get the dizzy, the nausea, all of that stuff combined with it.
Got it. That's a really great distinction. And I think that's where, and you mentioned this too, sometimes there's both, right? Mm-hmm. And so that's one of the reasons I'm really excited for the one-day course, the positive spin course coming up, is to kind of distinguish those and how we might assess them and treat them either like separately or together, right? And I think that's what sometimes what I find, and I know this is something that you have found a lot as well, is that we just kind of go one or the other. And like, it's not really that black and white. By the way, Catherine's here live as well. And I already put something in the comments. She said, to expand on Jaimy's great explanation, dysfunction is a problem with the end organ itself. So like you said, like there is actually a problem with the motor control for convergence, right? Or there's actually a canal problem. There's a vestibular hypofunction, or there's a disease process. While the hypersensitivity is a abnormal large reaction to a very normal input. And anybody who has this knows where it's like, they have a sensitivity to light, and then it's like they'll go in my treatment room here and it's like boom, dizziness from a fluorescent light, which it's like a heightened response to a normal stimulus, right? And that's happening in the brain. It's not an eye problem, it's not an ear problem, but it's the integrative function, right?
Right. And how I dose a dysfunction is going to be very different from how I dose
distinct. Are you still there?
I'm there.
Okay, I think what happened is our Facebook Live started playing live as we were going here. Oh. I was like, what's happening? That was our video going live at the same time we're going live. I'm surprised we didn't get a lot of feedback on it, but that was me being able to check our comments as we're going. So I apologize for that. And for everybody who is watching live and getting that extra sound going on.
Did it get missed? So all I was saying during that was that the dosage for somebody with an end organ, like Catherine said, dysfunction, is going to be very different than that hypersensitive, the person with the hypersensitivity, because their tolerance is going to be poor. And really, not only is it the buy-in, but the success and everything else that they need to actually master all those exercises change. And that's a big component of what we're trying to get people to look at a little bit differently. So it's hard because it's not black and white. It's not dysfunction and hypersensitive. And why can't I get them to reduce their symptoms, but person A can? And so that's our goal, is to try and tease out differences in our patients. And it really does relate to that functional connectivity, Julie, that you love so much.
That I love so much. Yes. That's great. And I appreciate Catherine for being here live. Thank you. And for further putting some words on that as well. And so then the question that I know we get a lot, right, in our Brain Bites group, and you and Catherine are, we even talked a little bit about this last night, is then like, how do we like know what to do like at home for a person, and maybe even grading some of the sensory weighting. So I wonder if you have a couple of tips for all us lost souls and like the sensory reweighting piece of dizziness.
Yeah, I think we need to give more love to the somatosensory system. And I always joke, like if I were to give you a test and you have like answer A, B, C, or D, you just always answer C, somatosensory. Like pick it. And most often you'll do really well with it. And it's what we learn in school. You know, if the person's dizzy, give them as much somatosensory. That's why sitting is better than standing, is better than walking. So for the person who does have actually dysfunction or hypersensitivity, maybe we need to work on weighting that system. And we talked last night about some of the strategies to use to really help these people be successful, and really that on and off switch of being able to really get them to a good baseline. I think that's sometimes the hardest part is, but their baseline's a 5 out of 10. Is that where we start? And I don't think you have to. I think you really could get these people down to a 2 and habituate up to that higher tolerable level, and then back down to a 2, hopefully a 0, and back up. So using somatosensory cues or even graviception is something that a lot of these patients need, but they haven't quite learned how to switch that connectivity to the somatosensory system. And that's another big piece of what we're talking about on next Saturday.
Can you believe that? I'm so excited.
So strategies to help the person pace a day where they know they have a lot of visual vestibular activity, and how to ground and come back and use that somatosensory system, or how to start the day before they're already driving that system up. How to do something and have that somatosensory cue so they can tolerate a certain activity would be sort of a concurrent strategy. And then like a recovery strategy, being able to, okay, I just did this activity. I wanted to play with my child, and now I just need a moment to recover and bring my symptoms back to baseline. So that's kind of key in dosing, and really getting the buy-in from the patient as well, because you've given them success and control in something that can help regulate and really calm not only it's really that autonomic nervous system down as well. As we know, there's just that functional connectivity as well with the autonomic nervous system.
Mm-hmm. So I wonder if like you said 3 things that were like, oh yes, every time I listen to you, Jaimy, I like get one more thing. And I know we talked about this last night too. The concurrent, I think, was the word, like in the moment strategy, right? The recovery strategy of like after the moment. And what was the third? Do you have one more word?
It was pacing. So again, like start off with a good baseline, do the activity, recover. It's kind of has a recovery element to it, but really being able to say and planning their day and knowing what visual vestibular stimulation might ramp up their system, and then a strategy to pace it and bring it back down. Because if they let themselves keep going up, they struggle a whole lot more. So they'll get control over a day versus maybe an activity that they're doing.
Yeah. That's great. And I think that is so helpful if we think of, and I know this is a big part of the course too, is like, well, how do it's not like everybody gets the same recipe of those things, right? Like each person is so individual. So it's like, how do we build those up for individual presentations, different presentations of symptoms, and give them a little bit of each of those for their day. So quite honestly, they need us less, right? Like we're building strategies, and they're like, heal yourself here, right?
Yeah, once they understand the concept, they do really well on their own and come back and say, hey, Jaimy, I'm great with, this is getting so much better, but I notice the grocery stores, not quite better. And this is now I'm getting into another part of the course, is really identifying, they say the grocery store, what's going on in the grocery store with visual vestibular and the proprioceptive system, and thinking about good history taking and what provokes their symptoms, so that we can streamline and create that mixtape that we're going for with the patient. But I rarely have, an exercise program that's the same for one as it is the other. I wish it would make my documentation really nice, but it's not.
I know it would make things easy, right? But then it also would like make our lives boring, right? That's what I think.
Fun part is,
fun part.
Yeah. reading makes you dizzy, I can associate that with, convergence or saccades. I can start to piece out some of those things and develop that program that matches their symptom, their problem, and then I can test it. I can match their dosage and their treatment according to whatever that is. And it's really, again, it's impairment versus sensory weighting analysis in any activity or condition, and then saying, okay, we need to sprinkle a little bit of something eyes closed, something with visual motion. But again, it has to be, really for that patient's problem, not just a blanket sort of exercise.
Mm-hmm. Mm-hmm. And I think that is precisely why you and Catherine created this course too, was like, you have seen if people do get kind of this like blanket exercise of vestibular rehab, for some that works, but for many, it actually makes them worse. Mm-hmm. And then you end up seeing them maybe down the road, and then the brain has made all these funky connections, and we're kind of, you're undoing that. So really putting together a course that takes this different spin, a positive spin on dizziness, and looks at it just from a different view of a very, very individualized approach. And I know I've already learned a lot of that from you, but I'm really excited to have it together in a whole day course.
So are we. It's been such a good experience for both Catherine and I. Actually putting it down to, it's something we've been doing for a long time, but finding the evidence, putting it down, organizing our thoughts so that they make sense to someone else, has been such a good learning experience. And I would say even I'm changing a little bit throughout this, so it's certainly helped develop us, and we hope we can pass that on to everyone else as well.
And you already have, I would say, in many ways. So, Jaimy, I want to thank you so much for joining me today to a little lunchtime chat. And for all the people, by the way, we share this with almost 2,000 people every week who are part of our newsletters. And we send, we did this great video with Catherine to talk about the mixtape on Wednesday. We do this video. If people are a part of our newsletter, I put those together along with some of those great articles that you shared and resources, and we send this out every Friday for people. So they get a little dose of some helpful tips and resources and things, and can hear about when we host people like you for a course, which is the Positive Spin on Dizziness course. It's coming up August 28th. It's a one-day course. It's live online, but it's also available recorded. So if you can't make it on the 28th, you can still be a part of the course, get all the great resources as well. So we're super excited. Jaimy Young actually asked in the comments here, how do I sign up for your newsletter? Let me put a link in there for you, Jaimy. We've got, by the way, we have 2 different newsletters that go out. Our newsletter for therapists goes out every Friday. And then we have a newsletter for people with neurologic dysfunction to get their questions answered. And that goes out every Monday. So I'll put links to both because I think you'll want what's directly helpful for you. And I would say too, if you're a person with dizziness and you're working with a therapist, you should tell them about this course. Like, they should go to it. If you've gotten stuck in your own progression of things, I think personally, this is where you should go, because this has certainly helped my own practice quite a bit, and my whole clinic, which hello, like we're seeing like 1,000 people a month. So Jaimy, Catherine, you're helping thousands of people a month. I just want to thank you personally, because that's why we all got into this, right? That's why we got into this profession, is to really be able to empower people to get back to their full lives. And you are I'm getting like emotional now, but you are like literally helping so many people by, what you have been able to like learn and do and practice and put together for us. So you're making such a big difference in so many lives. So
Thanks,
you.
Julie. That is huge. Thank you. I don't even know what to say.
No, it
Other
is.
than actually likewise, because you've changed my practice as well. So I just think this collaboration has been just such a huge growth in general. I love it. And it's great to help the next person.
Yeah, for all of us. So Jaimy, thank you so much. I'm so excited for next week. And thanks for joining our community today. We'll see you next week.
See you then. Bye.
Okay, bye.